Okay, well, hello everyone, and welcome to our Back to Basics webinar, New Syndrome, Understanding the Impact of Cardiovascular-Kidney-Metabolic Syndrome. We're very happy to have you here today. My name is Carrie Finley, and I will be your facilitator, and I'm joined by Rachel Dibble, who will do her own introductions when we get to that portion of the presentation. Let's go to the next slide here. Today's session is a part of a webinar series. Our webinars are on the third Tuesday of each month. We host them both at 12 o'clock Central or 1 o'clock Eastern, and then we repeat the same webinar at 3:30 Central or 4:30 Eastern. So on this slide, you can see some of the future topics we'll be discussing. In December, we will be focused on the importance of healthy holidays and different approaches you can do to ensure that your holiday is healthy, followed by January's presentation, which is what is your resolution as we move forward into the new year. And then in February is Heart Month, celebrating hearts. And so we will be discussing cardiac rehabilitation. At this time, before we move forward in the presentation, if you could take a moment just to enter your name and organization in chat. That way we will all get to know who's joined us today. So you can go ahead and do that while I pass the presentation over to Rachel to review learning objectives and the content of the webinar. Rachel?
Thank you so much, Carrie. Welcome, everyone, and thank you for attending. My name is Rachel Dibble. I am a nurse practitioner by trade, and really my specialties are chronic diseases and palliative and end-of-life care, hospice care. So our learning objectives today are examine cardiovascular-kidney-metabolic, which is CKM syndrome, as a new disease. Describe screening, symptoms, diagnoses, and management of CKM syndrome. Examine how preventative care strategies decrease the risk of CKM. Understand the importance of a patient-centered approach with CKM. So I just want to kind of summarize CKM in general. What this is it is a new diagnosis. And so this is a really important talk about this new diagnosis. Piggybacks off of metabolic syndrome. So it's really interesting how they put the two together and gotten more detailed about metabolic syndrome. So CKM is brand new, not a ton of literature out there about it, but I'm going to share with you what is out there in hopes that, that you learn a little bit more about CKM, this new syndrome. Next slide, please. So we're going to start with a polling question. So to get a baseline knowledge, and then we'll do the same question at the end. So a patient has excess adiposity, type 2 diabetes, uncontrolled, chronic kidney disease, and atrial fibrillation. What should the clinician do first? You guys are good. You guys are good. I will give you the answer at the end. Look at that, 50-50. Okay, very good. All right. Okay, next slide. So we're going to start with a case study as well. And what I'd like is this to be really interactive. We've got a small group. So please feel free to just jump in there via the chat. And I will, throughout the presentation, refer back to this case study. So here it is. So cardiovascular kidney metabolic syndrome case study. So we've got Mrs. Jones here. She's 69 years old. She's scheduled for an appointment in your clinic, or she may be in your facility or at the hospital. And and just so you know, she has not had a wellness exam in nearly 4 years, and she's 69 years old. Interesting. So we notice in her history that she has coronary artery disease. She's had 3 stents. Wow, 3 stents in the past year. She's a little lady, with a height of 5'6", and she's 280 pounds. Upon her exam, her blood pressure is 160/80, which is also her baseline, keep note. And she has protein in her urine. Oh my. Her labs reveal her creatinine is 2.4. She is somewhat compliant with medications. However, she does state that she rarely takes her diabetic medications because it makes her nauseous. Nor does she take her cholesterol medication, her simvastatin. At times, she may or may not take her diuretic because she complains that she stays up all night to go to the bathroom. So she only takes it when she feels like it. Mrs. Jones. Okay, let's go to the next slide. So let's just get down and dirty with what is this? What is this new syndrome? So it's a new diagnosis, as mentioned before, as of October 7th, 2023. So CKM, it is a syndrome of a multi-system disorder, and metabolic risks has led to the concept of CKM. So what does that mean? So we looked at metabolic syndrome, and what happened when we came up with metabolic syndrome, which is the umbrella term. You know, there's the criteria, there is the fasting blood glucose, there's the BMI, there is blood pressure, etc. You get 3 out of the 5, you have metabolic syndrome. And then what happened was the education was lifestyle, diet, exercise, and that was that, period, the end. But what happened to these patients was that they then suffered from chronic kidney disease and cardiovascular risks. And they were like, Medicare was like, what is the root cause of this? What is the root cause of cardiovascular risk in kidneys when we look at it in a metabolic syndrome lens? Well, what they came up with was it is weight, it is metabolic, and it is obesity. So this is the focus. And the days of diet and exercise, that can't really come out of our mouths that way anymore because it's not working. And people with behavior changes, with underlying chronic diseases, we're telling them to go do some lifestyle modifications. We got to rethink the concept, which is what CKM is. It is what CMS wants us to think about, because they're also looking at the dollar signs behind chronic kidney disease, behind cardiovascular disease. And they're putting all of this together for us. Finally, this is a blessing that they're doing this and saying, hey, we got to double down on this. So research shows that there is a direct correlation with heart disease and kidney disease. It is a circle. So if your heart's not pumping, you're backing up. If your kidneys aren't working, they're backing up. And where do they back up between the two? Your lungs, your heart, your kidney, edema in your fingers then. That's how you know you got a problem. So what happens is it increases morbidity and mortality. CKM does. Your heart's not working, your kidneys are not working, and your lungs are going to be affected. And your vascular system, because you probably have diabetes. Next slide, please. So cardiovascular metabolic syndrome, here's the background, and I've gone over this a little bit already. So the American Heart Association, so this is the presidential advisory statement. This is really all you're going to find if you look today about this syndrome. So what they are saying is, in their statement, what we have to look for is this kidney disease way ahead of time. So if you have someone that has excess adipose tissue or obese, you have got to screen for kidney disease. That is the evidence-based practice. At the diagnosis, metabolic disease. So we're looking at endocrine problems. Obviously, people with thyroid issues, symptomatically, it can contribute to obesity, or large habitus rather. Corticosteroids, you get the moon face. So these are all the metabolic things that we have to look for, the underlying, okay? We have to look at cardiovascular disease, hands down. We got to look at that EF. What is that ejection fraction? How is that heart pumping in and out? What is our creatinine? What is our serum creatinine as well? What's our ratio, our BUNs and our ratios? How healthy are our kidneys? Type 1, type 2 diabetes. Very, very important insofar as background. When you look at chronic kidney disease and vascular disease, what we know is diabetes shreds the whole vascular system, which is why they're saying we got to look at this disease head to toe. We got vascular system in every part of our body, okay? More than one disease increases mortality, specifically those patients with cardiovascular disease. We say cardiovascular disease and it just rolls off our tongue. But what does that mean? That's chronic disease. If you have cardiovascular problems, you more than likely have got a lot of kidney problems. You probably have some peripheral vascular disease. You've got some valve problems within your veins and et cetera, et cetera. So again, affecting your whole body. Cardiovascular disease affects every kidney, every organ, specifically kidneys in your body. So the advisory has connected cardiovascular disease with kidneys. It goes hand in hand. So opinions vary on how or what degree these conditions qualify as a syndrome. So the definition is not crystal clear. They are working on this, but the takeaway is it all works together. It is a head-to-toe situation. Next slide, please. Cardiovascular risk factors with kidney metabolic syndrome. So current scientific considerations of CKM, excess and dysfunctional adipose tissue. Metabolic risk factors, chronic kidney disease, cardiovascular disease. So when we look at these, I'm so sorry, I had a barking dog. So when you look at these risk factors, insofar as your chronic kidney metabolic syndrome, these are your risk factors. Again, you got to look at your endocrine, maybe your thyroids, maybe just your BMIs. Look at your chronic kidney disease and your cardiovascular disease. When you see these things, we have to screen. Next slide, please. Why does this matter? Why is this a big deal? Why is this statement coming out? And it comes out almost every day. Because metabolic disease can damage almost every system in your body, head to toe. True statement. It increases the risk of cardiovascular disease, including heart failure, AFib. What does AFib equal? Sometimes stroke. So right there, that's preventative care. We got AFib, we got to start thinking about stroke. Coronary heart disease, stroke as well. Peripheral artery disease, big deal. Okay, those are those patients that have that dry, scaly, very discolored lower limb, lower extremity. Those are those patients. You see that? We've got some coronary artery disease going on. So relationship accounted for 1 million deaths in 2021 of CKM. So they put it all together and figure out 1 million people die from basically cardiovascular kidney issues. True statement. Or 29% increase in estimated costs. Oh my goodness, this costs $1.7 trillion annually. That's crazy. And we can help mitigate this with proactive care, screening. We don't even have to talk to our patient. We can take one look at our patient and know that we need to screen them. That is our assessment right there in a nutshell. Next slide, please. Staging. So we've got some staging here that looks a little bit different than our normal chronic kidney disease staging, okay? So your CKM staging, so look at this. It focuses on the pathophysiology. So it doesn't focus on what has happened retrospectively. It is focusing now on prospective, future. I like it. This is what we need to think about. So we're looking at the patho, the risk factors, the prevention and care. So your stage 0, that's your healthy, either geriatric or 50-year-old, right? They can walk in, their wellness exam once a year, creatinine's always good, BUN's good, kidneys look good, liver looks good, heart looks good. We don't worry about them till the next year, right? And their glucose looks great, not at risk for diabetes, we're looking good. Stage 1. This is the problem with excess adipose tissue. The big problem is inflammation, okay? That's what it is, and insulin resistant. So when you look at it from a pathophysiology standpoint, that's the problem. It's not all the social stigma that potentially is out there, which there is. It is you're walking around inflamed, right? Just inflamed. So it's pro-inflammation and pro-oxidative secretion. So things are actually happening in your body, secreting. So this is causing tissue damage and it reduces insulin sensitivity. This is where we get our insulin resistant patient who then goes on diabetes medication to create more insulin or get the insulin that is working to get it to penetrate, right? But when all of that doesn't work, then, and they already have diabetes, then our kidneys are being affected. But our vascular system is being affected because we have diabetes. So now we have the heart, we have the kidneys because we have diabetes because of our dysfunctional adipose tissue. So let's go back and think about Mrs. Jones and these stagings. Okay, so now we have stage 2, metabolic risk factors. These are big, and these sometimes, as clinicians, we miss. So these are, we have hypertriglyceridemia. So basically you have some high triglycerides or high LDLs. Those are your lethal, those are your bad cholesterol. So we want those down, we want our healthies up, right? So then we have a little bit of hypertension, diabetes, we have metabolic syndrome. That's the umbrella, right? So what that basically means is we are diabetic, we are obese, we've got some metabolic issues going on. And we are moderate high risk to chronic kidney disease. Look at that. Low risk isn't in there because we're diabetic. So that's how you pull your kidneys in, your hypertension, you pull your cardio in, vascular system. Next slide, please. Next slide, please. Stage 3. Oh my. So right now we have CKM. We have CKM syndrome or risk equivalent. So we have Mrs. Jones, she's got diabetes, she has hypertension, she is obese, she's not really med compliant for good reason. So we're almost at stage 3, we're in trouble because we probably have some kidney disease and some cardiovascular. We got to move on this patient. We got to get her to a specialist and we got to get that blood glucose managed, Mrs. Jones, okay? So now we're at stage 4. So now we have some cardiovascular disease with CKM. Mrs. Jones has that. She has 3 stents in the past year. She's going down. We see that. She's in and out of the hospital now. She's having interventions done. We got to get on top of this because we're going to get to stage 4. And then we're going to look at staging of kidney disease and then staging of heart disease. Those are the 3 things we're looking at. In general, and Mrs. Jones really needs some help. Next slide. So your risk assessment, it's screening. You know, you can walk into a room and you can see someone who has a large habitus or is their BMI is high. That's all you need. You need a screen for diabetes, chronic kidney disease. Look at what their LDLs are, HDLs, triglycerides. These are labs. These are 10-second exercises. Right there, you could save this person's life or having a horrible quality of life and money they don't have being spent. That's all. That's what that does, that 10 seconds for that patient. Calculator risk tool. So we do have a slide, or excuse me, we do have a link to that. This is brand new, very excited. So you use this tool and they'll tell you what the risk is of mortality. They'll tell you where you are in the process. They'll tell the patient this. So we need to use this and we need to educate them on where they are in their trajectory of their chronic illness that's not going to go away unless we help them. Okay. Social determinants of health affects health and risk factors 100%, hands down. Hands down. These are expensive diseases. This system is hard to navigate. We got to help them get into some programs, help them with their social determinants, connect them with community. Next slide, please. Treatment and prevention. Again, we're looking at the excess body fat and insulin resistance. That's what it is. I mean, if that's your takeaway, that you take away one thing, that's what it is. And we got to look at some hearts and we got to look at some kidneys, okay? So it is the root cause of CKM syndrome, right? Lifestyle modifications and weight loss. We say that again, it rolls off our tongue. Lifestyle modifications, weight loss. Well, again, someone who had specifically with diabetes, amputation, neuropathies, glaucoma, all of these things that affect them. That's not an easy task. Lifestyle modifications and weight loss. That's hard. We have to help them. We have to hold their hand through those 3 words, okay? Early medications. Those are your metformins, particularly for diabetes, and your statins. Get that cholesterol down. Education and support is paramount, okay? These people in general with diabetes, it is a team sport. And that goes for anyone really with any socioeconomic background. My stepfather would be a wonderful story about diabetes, and he was very well managed. When I explained to him what it does, and what we need to do to manage it, I probably spent 30 minutes with him. He said, "Thank you. My endocrinologist has never explained that. He just gives me my diabetes medications and tells me that my sugar's good and sends me home." So he didn't know the why. He didn't know why it was so important, and that's why. And then with that, it gave him some momentum to do some of these things to protect his kidneys through lifestyle because he understood the why. Okay, next slide, please. Access to care and clinic approach. Access to care, huge, 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 huge. Holistic care, that's your head to toe. You know, I think in medicine in general, we look at one organ and we don't connect them. So that's why I'm excited about this diagnosis, that we're connecting organs now in medicine, go figure. IDT. IDT, you get so many ideas. I get so many ideas from my social workers and my community healthcare workers because they're very versed on resources. Social drivers of health. I can't emphasize this enough. We have to look at food. We have to look at food deserts. We have to look at medication access fiscally. How are we paying for it? Someone's on Medicaid. That paperwork is rough to get through. So helping your patients, again, community resources. I think too, we really need to lean on these resources. They're out there, but we have to help guide and navigate our patients to those resources and ensure the value of those resources. That would be very frustrating for a patient. Well, why don't you go here, 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 and here? You know, figure out the good ones in your area that has some value. Next slide, please. So what are your takeaways? Screen. Your risk factors, you really need to look at that because those are your chronic diseases, and some of them cannot be reversed, which makes your chronic disease trajectory situation snowball. Glycemic control. We don't want these hypoglycemic patients all the time because these patients sometimes, geriatrics, don't remember they took their medicine and don't eat sometimes. So they're hypo or they forget and they're hyper. So we need to make sure our A1C is not so tight on our 65 and overs. Our blood pressure, high blood pressure equals vascular damage and kidney damage, period. We got to get them down. Standard is 130/80, evidence-based practice. Your chronic diseases, know that these are chronic diseases and they will snowball on each other. You start with diabetes, then you get some peripheral vascular because your diabetes is not managed. Then you get some kidney disease. Oh my goodness, now you have some heart disease. Now your heart is damaged. Your EF is now in the 40s. Now you're on diuretics. Now you're on an antiarrhythmia because you have AFib now and you're going to have a stroke. So now you're on Plavix. So can you see how this all snowballs? All these, and it started from diabetes, right? And now this person has spent the last 10 years of their life managing all of these things because of diabetes. So important. Okay. Next slide, please. So the strengths of the literature. So the evidence supports CKM syndrome and raises health risks. There are gaps of understanding. This will all come out probably in the next 6 months to year. Real tight clinical practice guidelines, et cetera, that is not established at the moment. So heart disease and kidney disease, that happens typically because of inflammation and high blood pressure. Those are the 2 things, okay? Next slide, please. So the biological and chemical mechanisms progression of CKM by sex are not well understood. The numbers show that men are higher than women, but they don't know why. They're looking at lifestyles, they can't put it together. So I thought that was super interesting insofar as gender. So CKM and racial and ethnic groups and SDOH is likely influenced by environmental and lifestyle. We know that, okay? Goes into your psychosocial. Gaps in understanding CKM syndrome prevention and management. That's where those clinical guidelines have not come out yet. But what we do know is to screen diabetes, chronic kidney disease, and CKM. Screen. We know that 100%. Gaps in advocacy to promote insurance coverage and medications and support models. These are the two most expensive things you can have. Imagine being on a fixed income, okay? It's really important for these patients. They don't manage it typically because of the cost, okay? Next slide. So what happened to Mrs. Jones? So what happened to her was she was scheduled for an appointment in the clinic. Next slide, please. So I'm sorry, I thought this was, I apologize. So what happened to Mrs. Jones was that Mrs. Jones, you can go ahead and go to the next slide. So what we did with Mrs. Jones is that we did, and here's your polling question. Actually, why don't you answer this first, and then I'll go back to Mrs. Jones. We'll do that. Okay, so your patient, same thing, has excess adipose tissue, uncontrolled diabetes. Okay, so we're going to go with all the above. So what should they do first? The first thing you do is screen. So insofar as answering that question correctly, you did insofar as first. But then you also have to screen for metabolic syndrome. You can probably figure that out from your CKM. Then you need to discuss your risk factors. This is before this patient leaves, okay? Okay, so this is exactly what happened to Mrs. Jones. So Mrs. Jones, so this is what we did with her. We discussed lifestyle modifications, but what I learned about Mrs. Jones, because of her habitus of 280 pounds, she is really not so mobile. I also found out through my interview with her that she had just had 2 knee replacements a year ago and has a hard time with PT. So these are the things that I'm listening to her about. She also has a really hard time getting out of bed to go to the bathroom because of her Lasix, right? So insofar as lifestyle modifications, what I did was I asked her, what can you do? What's comfortable for you? She said, you know what? I can get on my walker and I'm okay going to the mailbox and back. I can do that. And it's about 20 feet long. So it's 40 feet round trip. I said, terrific. Let's do that twice a day. Can you do that? Do you think you can do that? Is that manageable? Do you have the time? Are you safe? All the things. She said, well, yeah, I can. Of course I can do that. Awesome. You're excited about it and you can do it. So let's put that down. Okay. So her risk factors, oh my, she's got a lot of them. We know she's got heart disease. She's got some kidney disease. She's got some neuropathy. She's got big piece here. She's got depression because she said, I don't feel so good. I just feel down. I feel this. Well, of course you do. You can't move. You've got diabetes that is totally uncontrolled. Of course you don't feel well. So let's screen for that. Let's get out our tool, our depression tool, and whichever one you use in your practice. And let's see where you are, because I bet you a little Zoloft might help you there. Or when you get moving, that's going to help you. Okay, so then with Mrs. Jones, we talked about cardiovascular health. We talked about her cholesterol. And what I found out was she didn't understand healthy cholesterols. She didn't know that if she ate fruits and vegetables and got those healthies up, she can actually reduce her bads, and that her healthies actually trump her bads if she can't get her bads down. So I said to Mrs. Jones, can you eat like 2 salads a week? Can you afford that? Do you have access? She said, well, I go to McDonald's all the time. I said, well, don't they have a good salad? She said, well, you know what? Come to think of it, they do. And I have a coupon on my app. Every Tuesday they have this salad. Terrific. Let's put that down. Figured out her diet or helped with it. These are the baby steps. So we got her some cardiovascular help. We've screened her. We've gotten her some kidney. We helped her understand her kidney issues, her diabetes. We've talked to her about salads and diets and carbs. We've educated that so she's not back with a hyperglycemic event. We've trained her about hypoglycemia and about how important the schedule of her insulin and eating is. So we've wrapped her up and put a nice bow. Now we can't just send her off and hope that everything goes well. It's our follow-up. We need to follow up with that patient every month. And if she needs to go to a nephrologist or cardiologist, we need to ensure those appointments were made and that she was able to go because she had access to care. That's when diabetes and chronic kidney disease gets messy because you're at every specialist because it affects every organ. But you can be the leader as a primary care and navigate all of these specialists and the patient can come back to you with the information. You can connect the dots for that. And that's what needs to happen. And it's constant. It is a constant re-education, education, baby step, supportive, patient-centered care. So I'm going to leave you on that note. And that's what I hope we do for these patients. And I hope that CKM has just triggered your thoughts to be a little bit different related to metabolic syndrome or people with excess adipose tissue, because it can be for multiple reasons, particularly metabolic, that we have no control over. Okay. Please, please, please ask your questions. We are here. It's a small group, so we're here for you. Thank you so much.
Okay, thank you, Rachel. At this time, we can open it up if there's any questions from the group. By all means, you can please unmute yourself and ask the question, or you can also enter the question into chat. Rachel, I do have one question, and it's for just in general, like, is there a certain age that you should just automatically do screening regardless of symptoms?
So thank you for asking that, actually. And I didn't put it in here for a very specific reason. So the age is 35 at the moment, meaning like literally at the moment. So that is the recommendation. They have not 100% said that's a guideline, but the thought today is 35.
Okay, thank you.
For me, sorry.
Oh, no, go ahead.
For me personally in practice, it goes for anyone I screen because it's your normal blood work, just screen for proteins in your, like, it's easy to do and it's not expensive. So that is my personal practice.
All right, thank you. And there is a question in chat. This is from Michelle. Is the Prevent risk calculator tool available for free? And then if so, what is the link?
I thought that,
and I believe we have that. There's the slide with the link to the risk calculator.
have you guys, the people are still, I don't know how many we have on. Okay. Have you guys, you can't get the link to work.
Oh, okay.
Maybe if we American Heart Association, maybe just go there and snag that one, maybe, I don't know.
Yep, I'll check that too, Michelle. And what we do is we send a follow-up email every month with information with our next website. We can add the link to that, and I'll also post the updated link in Connect. So we'll make sure we get that to you.
And I'm personally just very personally curious. Have you all heard about this or read about this? Is the message kind of out? And I would love to have just a pulse on it. I have no clue.
Well, I'm not seeing anything in chat yet, Rachel.
Okay.
Okay. Well, I can move on here. Here's Rachel's information. If you have any additional questions, you can certainly reach out to her or to anyone on our chronic disease management team. Your feedback is very appreciated for this presentation, and it helps us to develop future content. And for this session, we are offering certificates after the completion of the evaluation, and that certificate will be emailed to you. So please fill out that evaluation so we can better meet your needs. And we do have some additional resources available to you. We are doing a Shine a Light on Stigma campaign. And if you have if you would like additional information on stigma and how words matter with substance use disorders, the link is there. And there are some very interesting podcasts on that topic as well. As I mentioned, I'll be posting the updated link for the tool from the American Heart Association on Connect. If you haven't signed up for Connect, this is the link to continue the conversation. And then we do have additional tools and resources available. We have documentation and coding guides, and also a food is medicine resource guide that are available to you. And we have the links included on this slide as well. As I mentioned, today's session is a part of a webinar series. These are the upcoming topics, and we hope that you're able to join us. So for next steps, if you've registered for this session, you've most likely registered for future webinars. However, please double check. This is the link to the registration, or share with members of your team. Sign up with Superior Health Connect. And then if you have any additional questions or would like some one-to-one assistance with your practice, Jerry Hineker will be your contact, and this is her email information for that. So at this time, if there aren't any additional questions, we'll conclude our webinar for November. Thank you very much, everyone, for joining us today. We hope that you enjoy the rest of your week. Thank you.